presentation on the cluster of Cook, which is designed to test for myelopathy of the cervical spine. Cervical spondylotic myelopathy is the most common cause of atraumatic spinal cord injury in the elderly, which shows the need for a cluster such as Cook's. The cluster is comprised of 5 different parts. These are 3 tests and 2 patient characteristics. These are gait observation, the Hoffman sign, the inverted supinator sign, the Babinski sign, and the client's age. The video following this introduction will explain each part of the cluster, why it is well suited to the cluster, and demonstrate how it is completed. The Hoffman test was developed approximately 120 years ago by Joanne Hoffman. It was designed to test for disease of the corticospinal pathways of the spine, such as cervical spondylotic myelopathy. It has also been referred to as the snapping reflex, the digital reflex, Jacobson's sign, and Chomner's sign, and it is part of the cluster of Cook. This test has a sensitivity of 59% and a specificity of 49% according to physio-tutors. To perform the Hoffman's test, you put the patient's arm on yours and cradle it. You then ask them to completely relax while you grasp the end of their middle phalanx with your thumb and forefinger, and then flick it downwards quickly. And a positive test is the approximation of the patient's index finger and thumb. This test has a second way that it can also be completed and is called the dynamic Hoffman sign. This test involves the same action but with the neck in full extension. This is thought to increase the likelihood of diagnosing cervical myelopathy in early stages. Of the Hoffman sign. Handal et al. Looked at 51 patients with cervical spine complaints and found the Hoffman sign to be the physical test with the most sensitive and the most accurate results. The study found that of the 51 patients studied, 10 had been previously imaged and had been told to have cervical spondylotic myelopathy. All 10 of these patients were picked up in the test via the use of the Hoffman sign. Another option to diagnose cervical myelopathy is the Clonus test. This test involves taking the knee and hip flexion, the hip into slight external rotation, and rapidly dorsiflexing. This test is sometimes used in diagnosing upper motor neuron lesions such as cervical spondylotic myelopathy. This test, however, has a sensitivity of 13%, meaning the Hoffman sign would be more useful in this test cluster as it helps to bring up the overall accuracy of the Cook cluster.
The inverted supinator sign, or the inverted supinator reflex, is commonly used in clinical practice to assess cervical myelopathy and was introduced by Babinski in 1910. This test is one of the 5 tests that make up the cluster of Cook. This sign specifically indicates spinal cord disease at the C5 to C6 level, and according to Cook in 2009, the inverted supinator sign has a specificity of 78% and a sensitivity of 61%. These values of the test indicate it to have a weak clinical value unless used in conjunction with other tests. The supinator reflex is tested by striking the lower end of the radius, just above the wrist with a tendon hammer. This normally causes contraction of the brachioradialis and hence flexion of the elbow. If the only response is finger flexion, then this reflex is said to be inverted. An inverted brachioradialis reflex is associated with an absent biceps jerk and an exaggerated triceps jerk. To conduct the test, have the patient in a sitting position, support the patient's forearm with your arm to ensure it's relaxed, slightly pronate the forearm, and locate the styloid process of the radius at the attachment of the brachioradialis. Then, apply a quick series of taps at the styloid process with a reflex hammer. A positive test will result in rapid finger flexion. Another test that can be used is the Sperling's test, which is used during a musculoskeletal assessment of the cervical spine. When looking for cervical nerve root compression causing cervical radiculopathy or cervical myelopathy. There are different ways described in the literature to perform the Sperling's test. The version that provoked arm symptoms the best was with the neck in extension, lateral flexion, and axial compression. The diagnostic accuracy of the test is a sensitivity of 50% and a specificity of 88%. According to study results, Sperling's test is most provocative when the head is in extension, lateral flexion to the affected side, with axial compression. It is important to elicit distal pain distribution to distinguish between cervical radiculopathy or cervical myelopathy. Although the test is commonly used for assessing cervical radiculopathy and myelopathy, it is important due to its lower sensitivity that other tests need to be used in conjunction. Therefore, the inverted supinator test is a better test to use to diagnose cervical myelopathy, but still is more accurate when other cluster of Cook tests are used.
In the cluster of Cook, age is used to determine whether or not someone has cervical myelopathy, because degeneration of the cervical spine is a major cause of cervical myelopathy, and degeneration is a natural part of aging. Due to disc degeneration, formation of bone spurs, osteophytes, and these can project into the spinal canal. It is rare to see cervical myelopathy in young people without them having experienced a major trauma. Age is in the cluster of Cook because of degeneration, as it is linked to aging, and as age goes up, the likelihood of having cervical myelopathy increases. The cluster of Cook is gait, and the reason why gait is used in the cluster of Cook is because the person's gait is the first sign that something is wrong, whether it be neurological, muscular, or skeletal, and then further investigations will be needed. It is also a non-invasive, as the practitioner does not have to touch the patient. Furthermore, it can also be used to gauge whether or not the treatment is helping. A person's gait in cervical myelopathy is a wide, broad-based, staggering gait with clumsy movements and slow swinging of the legs. It occurs due to compression of the corticospinal tract. Gait is used over other tests as it is a quick and easy way to assess someone, as you can just assess them as soon as they walk in. Using the Neuric classification system, you can also grade the extent of someone's disease. I'm going to demonstrate a cervical myelopathy gait, so broad-based ataxic gait, and it's a lot of trunk, like balancing movements and swinging of the legs, because they have no balance.
The two tests that I will perform will be the Babinski sign and Lemaitre sign. Firstly, Babinski sign. This is a reflex indicative of damage or problems with the corticospinal tract. The Babinski sign was explained by a neurologist by the name Joseph Babinski in 1899 and is a pathological indication of disturbance to the pyramidal system. The tissue that is challenged during this test is the corticospinal tract, which is responsible for the cutaneous plantar reflex response at the base of the foot. The extensor sign, viewed as the Babinski sign, is an indication that the receptive field of normal toe extension is enlarged in individuals with an upper motor neuron lesion. To perform the Babinski sign, the patient should be comfortable and lying supine. The practitioner takes a blunt object, such as the rounded edge of a reflex hammer, and runs that gently along the lateral aspect of the foot forwards from the heel towards the great toe. A positive Babinski sign results in extension and abduction or fanning of the toes. A normal result is plantar flexion response of the toes. According to a study done by Giamello et al., the Babinski sign has a specificity of 99% and a sensitivity of 51% in identifying pyramidal tract dysfunction. Another secondary test in this cluster that can be conducted is Lemaitre sign. To perform the test for Lemaitre sign, the patient is to be seated in a comfortable position. The practitioner stands behind the patient and gently flexes the patient's neck into forward flexion. Any pain or discomfort should be noted. The challenge during this test is the dura, and a positive test results in tingling electric-like sensation that runs down the spine and into the extremities, suggesting dural meningeal irritation. Although both Babinski's and Lemaitre signs can be indicative of cervical myelopathy, due to the low accuracy of Lemaitre sign, it is more beneficial for us as chiropractors to use Babinski's sign in the clustering. The evidence points to this too, as Lemaitre sign is deemed more of a provocative test and does not have a specificity or sensitivity that can be accurately stated, whilst Babinski's sign has a very high specificity of 99% with a sensitivity of 51%.